Hi guys, this is Dr. Pawan and today I'm here to talk to you about a Surgery 101 revision session. Now, I thought that your NEET PG exam is around the corner, so let us begin with a new series which is Surgery 101. It means surgery one-on-one, like you and me, one-on-one, and we will be revising general surgery with you. So this session, like many others which we have done in the past, is going to be completely MCQ based, and I'll be talking about that particular MCQ in detail. Okay, so let's begin and let's talk about this particular session. Okay, right. So the first question which I have for all of you guys is, all of the following statements about a contrast medium are true except. So which of these following statements about the contrast medium is not true? Is it like a routine steroid prophylaxis is not advised for the patients at risk of allergic reaction? And acetylcysteine is recommended for the renal protection in the high-risk patients. Gadolinium containing contrast agents can lead to nephrogenic systemic fibrosis. Metformin can be continued safely in the patients with normal renal function. Now, what you need to understand is that when you perform a contrast enhanced CT scan, CCT, obviously you are giving the contrast to this particular patient. And this particular contrast, if at all, is given to the patient, and this patient may land up into CIN. Now, what is the CIN? CIN stands for contrast induced nephropathy. Okay, it lands up into contrast induced nephropathy. Now, not all patients land up into this, but yes, there is a propensity that the patient might land up into contrast induced nephropathy. Okay, well, it does, it may land up into that. Now, this particular question is trying to ask you which of these statements regarding the contrast medium is not true. Now, let us take it one by one. Routine steroid prophylaxis is not advised for the patients at risk of allergic reaction. It is a true statement. Now, do you give a routine steroid prophylaxis? Well, not. It is not recommended at all. Now, let's talk about this N-acetylcysteine. Let's say if at all somebody wants to get a CT scan done, we, before giving a contrast, we check for the creatinine level. Now, the creatinine level, the normal, which is kind of there, is 1.2 to 1.4. This is kind of normal. But even if the creatinine level is still 1.8, we can give it. Okay, even if the create is still 1.8, contrast can be given. Now, what you need to understand is, there was a practice that if at all, let's say there is a borderline creatinine excess. So if at all there is a excess creatinine, borderline, like there is slightly increased creatinine level, if at all this is a condition, then what you need to understand is that there was a kind of a practice to give N-acetylcysteine. It was thought to be renoprotective. It was thought that this N-acetylcysteine will protect us against whatever, like the contrast induced nephropathy. But it has been proven now that N-acetylcysteine is not renoprotective, and that is why it is not advised. So earlier, yes, it was kind of used. It was used very, very commonly whenever there was a borderline kind of elevated creatinine level. But your Levin-Bailey specifically writes, and it is kind of a true statement, and is given in Levin-Bailey, that N-acetylcysteine is not recommended. Okay, it is not recommended as a protection against the risk factor. It means that against the protection if at all the patient is having a borderline elevated creatinine. Now, gadolinium. So what you need to understand is that gadolinium is a contrast agent for what? So we have gadolinium. Now this gadolinium, this is what is a contrast used in. This is a contrast used in MRI. You have a contrast which is used in MRI. Now what you need to understand over here, gadolinium is a contrast which is used in MRI. Now, if at all the patient is having low renal function, if at all the GFR is less than 60, the patient is at an increased risk. There is an increased risk that the patient might land up into nephrogenic systemic fibrosis. Okay, so if at all gadolinium is leading to a reaction, it will cause fibrosis. So it will cause fibrosis across the body. Are you able to understand this point? It will lead to nephrogenic systemic fibrosis. Now, lastly, about the metformin. Okay, lastly about the metformin. Now, what you need to understand regarding the metformin, guys. Metformin, it was kind of thought that it needs to be discontinued. Now, let me just tell you about the guidelines. So, there are two things. Okay, let's say two things. If at all the patient is having a normal renal function, the metformin can be continued. It can be continued safely. But at the same time, if at all the metformin is having, if at all there is a person who is on metformin and the patient is having a borderline deranged renal function, if at all this is kind of present, then what you need to understand, metformin should be discontinued. 24 before CCT, and it can be started after 48 hours. It can be started after 48 hours of the procedure. Are you able to understand this point? So this is all about this particular question. What you need to understand, N-acetylcysteine, it is not recommended as a renal protective agent if at all there is a patient who is having a borderline increased kind of creatinine level. Now moving on to the next question, guys. Which of the following statements about Meckel's diverticulum is true? Okay, which of these is true? Meckel's diverticulum is a type of a false diverticulum. Well, no, it is a false statement. Now, it occurs along the mesenteric border. Well, again, it is a false statement. The most common presentation is hemorrhage. Yes, that is kind of a true statement. And heterotopic epithelium are absent in the Meckel's diverticulum. Again, it is a false statement. So it was a pretty simple question. Nothing great about it. Now, let us talk about Meckel's diverticulum in detail. So this is what is a laparoscopic image of what you're seeing is a Meckel's diverticulum. So let me just talk to you about Meckel's diverticulum in detail. Meckel's diverticulum. This is a true diverticulum. What do you understand by true diverticulum? It is having all the layers of intestine are present. So this Meckel's diverticulum, what is the cause of it? What is the cause? So it is basically a congenital anomaly. It is congenital and it is caused because of a persistence of vitellointestinal duct. Okay, so there is a vitellointestinal duct which we have in the embryonic period, and if at all this vitellointestinal duct persists, it leads to the formation of a Meckel's diverticulum. Are you able to understand this? Now, this is what is present along. The characteristic feature is it is a true diverticulum. I already told you this. And it is kind of present along the mesenteric, it is basically present along the anti-mesenteric border. Now, what do you understand by it is present along the anti-mesenteric border? So what you need to understand, there is intestine like this, and then there is mesentery. So there is a mesentery which is attached to the intestine. Now, this particular diverticulum is present on the mesentery, on the border which is opposite to that of mesentery, and that is why it is called as an anti-mesenteric. So what do you understand by anti-mesenteric? Opposite to mesentery. Okay, so it is basically present on the anti-mesenteric border. Now, if I talk about, so here in the Meckel's, there is ectopic tissue rest. Most commonly it is a gastric tissue. So if at all you have a gastric tissue which is present in the Meckel's diverticulum, what is it going to do? So let's say if at all this is a gastric tissue which is present in the Meckel's diverticulum, it is going to secrete HCl. This HCl is going to act on the wall. This wall is going to ulcerate. There's going to be ulceration, and because of this ulceration there is going to be bleeding. Okay, so ectopic tissue rest, which is usually gastric tissue, it is going to produce HCl. HCl is going to act on the wall adjacent to it, and it is going to cause ulceration, ultimately leading to a bleeding. Okay, so this is why the most common presentation of Meckel's diverticulum, if they ask overall or in children, the answer is bleeding. But if the same thing, if they ask you what is the most common presentation of the Meckel's diverticulum in the adults, so if they ask you what is the most common presentation of Meckel's in adults, the answer is obstruction, intestinal obstruction. This is the most common presentation of the Meckel's diverticulum in the adults, right? Now, let's talk about the management. So if at all there is a patient who is having a Meckel's diverticulum, what about the treatment? Now, what you need to understand, you have to evaluate the base. If at all the base is involved, what you need to go in for? You need to go in for a resection and anastomosis. You have to go in for a resection and anastomosis. But if at all, let's say the base is not involved, if at all, let's say the base is not involved, if at all the base is not involved, you can go in for a diverticulectomy. Okay, so obviously if at all there is a base which is involved, okay, what do you understand by diverticulectomy? Diverticulectomy is nothing. If at all, let's say this is a Meckel's diverticulum, and you can just go inside and you can cut this particular Meckel's diverticulum like this. This is what is called as a diverticulectomy. So if at all the base is not involved, you can go in for a diverticulectomy. But let's say if at all the base is involved, if base is involved, then you have to go in for a resection and anastomosis. You have to cut this particular part of the Meckel's diverticulum, you have to remove it, and you have to go in for an anastomosis of the intestine. But what you need to understand is that in your Love and Bailey, it has been written that if at all you have a wide mouth, you can go in for an observation. So if at all they characteristically use this particular word that, wide mouth, Meckel's diverticulum is present, you can go in for an observation. And if at all you have a narrow mouth, if you have a narrow mouth in there, like narrow mouth with the Meckel's diverticulum, here you can go in for a diverticulectomy. If at all, you have to go in for a diverticulectomy. Now, what I'm talking about this is what is an incidentally detected. Okay, this is for an incidentally detected. Detected Meckel's. So if at all they say that there is an incidentally detected Meckel's and it is wide mouth Meckel's diverticulum, you go in for an observation. And if they say incidentally detected Meckel's with a narrow mouth, you go in for a diverticulectomy. But let's assume that nothing is mentioned. They just mentioned incidental detected Meckel's. What you go in for? You have to go in for a diverticulectomy. So what you need to understand, in the Sabiston they have written that if at all you have an incidentally detected Meckel's, you go in for a diverticulectomy. But if they specifically mention that incidentally detected Meckel's with a wide mouth, you have to go in for an observation. With a narrow mouth, you have to go in for a diverticulectomy. I hope you are able to understand this particular point, guys. Right. So what I'll do, I'll just concise this Meckel's diverticulum for you. Very simple. Meckel's diverticulum, it is a true diverticulum. It means that it is containing all the layers of the intestine are present. It causes, what is the cause of this? It is a congenital. It is basically because of a persistence of a vitello-intestinal duct. So what you need to understand is a true diverticulum. It is present along the anti-mesenteric border, that is opposite to the mesentery. Meckel's diverticulum, here the ectopic tissue rest is present. The ectopic tissue is usually is the gastric tissue. If at all there is a gastric ectopic tissue rest present, HCl can be secreted. HCl can act on the kind of a wall adjacent to it. It can lead to ulceration, leading to bleeding. This is how the patient presents to you. So if they ask you what is the most common overall presentation or the most common presentation in the children, definitely the answer is bleeding. But if they ask you what is the most common presentation of the Meckel's in the adults, the answer is obstruction. Now for the management, if at all the base is involved, you go in for a resection and anastomosis. If at all the base is not involved, you have to go in for a diverticulectomy. Now I told you that incidentally detected Meckel's diverticulum, if at all it's a wide mouth, you have to go in for an observation. If at all it is a narrow mouth, you have to go in for a diverticulectomy. Now, which of the following statements is true about right-sided Meckel's diverticulum? Right-sided colonic malignancy. Now, there are two types, like there is a right-sided colonic malignancy and there is a left-sided colonic malignancy. So which of the following statements is true about the right-sided colonic malignancy? They are typically presenting as with an intestinal obstruction. Well, no, it is false statement. Iron deficiency anemia as the presentation in most cases. Yes, it is a true statement. Now, narrow caliber of the stool is an important finding. Again, another thing, it is more common in the left-sided. And CT scan is usually the first diagnostic study. Well, no. CT scan is not the first diagnostic study. You will go in for a workup and then you have to go in for a USG. Obviously, like this is the pattern which you will follow. And then if at all you have a suspicion, then you will go in for a CT scan, guys. Now, what I'll do is, I'll just summarize the important differences between right and left-sided colonic malignancies. So we have a right-sided colonic carcinoma and we have a left-sided colonic carcinoma. Now, okay, which is more common? Obviously, the left-sided colonic carcinoma, this is kind of most common and most commonly it is present in the sigmoid. Okay, now what you need to understand over here, the important crux of the matter is the right-sided colonic malignancy, they present as a fungating growth. Okay, they present as a fungating growth. Because it presents as a fungating growth, because of this, what is going to happen? There is an occult bleeding. And because of this occult bleeding, what is happening? Because of this occult bleeding, the patient is going to land up into anemia. Okay, so because of this occult bleeding, the patient is basically having anemia. Now, on the other hand, on the left-sided colonic carcinoma, what you need to understand here, basically there is a growth which is presenting with a stricture and scarring. In other words, it is fibrosing growth. So because there is a fibrosing kind of a growth over here, what you need to understand to begin with, there is altered bowel and there is reduction in the caliber of the stool. Okay, so there is reduction in the caliber of the stool. Followed by this, the patient may develop constipation. And ultimately, if it all this continues, the patient will end up into intestinal obstruction. Okay, I hope you are able to understand this point. This is a basic difference in the presentation of the right-sided and the left-sided colonic malignancy. So here we have a fungating growth on the right side, and that is why you have occult bleeding, ultimately leading to anemia. On the left-sided colonic carcinoma, you have a growth which is stricturing, scarring, and the fibrosing. Because of this, there is an altered bowel kind of movement. There is reduction in the caliber of the stool. Because of this, the patient lands up into constipation, ultimately leading to an intestinal obstruction. Okay, I hope you get this. This is right and the left-sided colonic carcinoma, the basic differences. Okay, right. So let's move on to the next question. So what is the diagnosis of this particular patient? So here you are basically seeing an X-ray, and what I'm trying to ask you is that what is the diagnosis of this particular patient? So guys, please understand, It is a characteristic coffee bean appearance. Okay, what is it? It is a characteristic coffee bean appearance, and that is why the diagnosis of this particular patient is a sigmoid volvulus. Okay, it is a sigmoid volvulus. Now, okay, let us talk about the sigmoid volvulus. So first of all, what do you understand by volvulus? Volvulus basically means that it is twisting on its own axis. Okay, it means that it is twisting on its own axis. So what do you need? Sigmoid is twisting on its own axis. That is what is you mean by a sigmoid volvulus. Now, obviously, there are few characteristic features of this. Like sigmoid volvulus, it is usually occurring in the anti-clockwise direction. Anti-clockwise direction. The patient is going to come to you with a severe abdominal pain. With vomiting. Okay, severe abdominal pain with the vomiting. This is how the patient is going to present to you. Right, that's all fine. Now, I will just ask you, what are the predisposing factors? Okay, so what are the predisposing factors for the development of a sigmoid volvulus? So what you need to understand, if at all there is a patient who is having chronic constipation. Okay, if at all there is a patient who is having chronic constipation, or there is narrow based mesentery. These are the important predisposing factors for the development of a sigmoid volvulus. Now, if at all you perform a barium enema in this, you will get something which is called as a ace of spades sign. Ace of spade sign. And this is what is your ace of spade sign which you are getting over here. Are you able to understand this point? So this is what is your ace of spade sign which you are getting over here. Right? So this is an ace of spade and we are getting an ace of spade sign, and this is what is again prompting you that okay, this is a patient who is having a sigmoid volvulus. Okay, now what about the cecal volvulus, guys? What about the cecal volvulus? So if at all they give you in the question that you know what, there is a comma shaped cecum, or let's say there is a kidney bean appearance of cecum, then you might have a diagnosis of a cecal volvulus. So just remember this, kidney bean shaped air kind of shadow is seen, or a comma shaped cecum is seen. This is what is prompting you that okay, this patient is suffering from a cecal volvulus. Now, the next question which I have is, what is the ideal treatment for a patient with carcinoid tumor of the appendix that is measuring 2 centimeters in size? So if at all there is a carcinoma tumor of the appendix which is having 2 centimeters in size, how will you manage this? Will you go in for a right hemicolectomy, appendectomy with a total colectomy, or chemotherapy? So answer to this particular question is right hemicolectomy. So let us kind of tell you about the management protocol of an appendical carcinoid. Management of carcinoid tumor of appendix. So what about this, guys? What about this management of the carcinoid tumor of the appendix? What you need to understand, this can be divided into, like the appendiceal carcinoid, it can be divided into less than 1 centimeter in size or more than 2 centimeters in size, and then between 1 to 2 centimeters in size. So if at all there is a carcinoid tumor of appendix which is less than 1 centimeter size, only simple appendectomy is enough. Okay, simple appendectomy is enough. Now, what about if at all there is a carcinoid of the appendix which is having more than 2 centimeters in size? What is the answer over here? You have to go in for a right hemicolectomy. You have to go in for a right hemicolectomy. Are you able to understand this point? So here you have to go in for a right hemicolectomy. But if at all, let's say there is a carcinoid tumor which is between 1 to 2 centimeters, what you need to understand is that if at all it is present on the tip of the appendix, or the meso appendix is not involved. Okay, so if at all it is present at the tip of the appendix or the meso appendix is not involved, then you have to go in for a simple appendectomy. But if at all it is basically present at the base of the appendix or the meso appendix is involved, then you have to go in for a right hemicolectomy. Okay, so this is the management protocol. This is how you will manage a patient of an carcinoid tumor of an appendix. If at all it is less than 1 centimeter, simple appendectomy is enough. If at all it is if at all it is more than 2 centimeters, you have to go in for a right hemicolectomy. If at all the tumor is basically between 1 to 2 centimeters, if at all it is involving the tip or the meso appendix is not involved, then simple appendectomy is enough. If at all it is involving the base and the meso appendix is involved, you have to go in for a right hemicolectomy. Okay, right. Now, last question which I have for you guys is most common organism which is causing emphysematous pyelonephritis. So which is the organism which is causing emphysematous pyelonephritis? Is it Staphylococcus aureus, E. coli, Pseudomonas or Proteus? What do you think is? What is the answer over here? So emphysematous pyelonephritis means air. Okay, so air in the kidney. Okay, so answer is E. coli, guys. Okay, please understand, do not mark it as your Clostridium or something like that. The answer is E. coli. So here the Clostridium is not given in the option, but even if the Clostridium is given in the option, please don't mark that. Now let me just talk to you about emphysematous pyelonephritis. Emphysematous pyelonephritis. Now what about this emphysematous pyelonephritis, guys? It is a infection of the kidney. Okay, it is an infection of the kidney in which there is air around the kidney, which is air accumulated in renal parenchyma. Okay, so it's an infection of the kidney in which there is an air accumulation in the kind of renal parenchyma. Now, one of the important MCQs which they keep on asking you is, what is the most common organism? It is E. coli. Okay, it is E. coli. Now, how will the patient present to you? What will be the clinical features? So yes, the patient is going to have all the features of a UTI, like your febrile and increased frequency, burning, micturition, all those stuff. But along with this, the characteristic thing which they will be having is pneumaturia. Okay, there will be pneumaturia. Now, what do you understand by this pneumaturia? Pneumaturia basically means that there is air in the urine. Pneumaturia basically means that there is air in urine. This is what you mean by a pneumaturia. Are you able to understand this point? So pneumaturia, yes, it is definitely present in emphysematous pyelonephritis, but it doesn't mean that it is present only in the emphysematous pyelonephritis. It can be present in many other conditions, like let's say diverticulitis as a complication of diverticulitis, and let's say by tuberculosis of the intestine or Crohn's disease where there is a fistula formation. So all these are the places where you might have a kind of a pneumaturia. So two things which you need to understand: E. coli and pneumaturia. If at all they are giving in the kind of scenario with the background that the patient is having UTI and the renal infection, definitely the diagnosis is emphysematous pyelonephritis. Now, I hope you are able to appreciate that this is an X-ray. What are you getting on an X-ray? That there is air around the kidney. So if at all there is an air around the kidney, this is what is trying to tell you that again this is an emphysematous pyelonephritis. Now lastly, what about the treatment? How do you manage this particular patient? So you go in for a percutaneous drainage. Okay, you go in for a percutaneous drainage along with antibiotics. And if at all the patient doesn't respond, if at all this particular treatment fails, then you have to go in for a surgery. You have to go in for a nephrectomy. Okay, so this is all, guys, which I wish to talk to you about. Thank you for watching this particular session. This was your episode 1. I will be continuing this in one form or the other. I'll be coming up with your based questions and all those stuff. So thank you so much for attending it, and yeah, stay tuned for further sessions, guys. At the same time, what I want to tell you is I am basically Dr. Pawan. I hope you know me. So I am basically an educator of surgery on Unacademy platform. Now, if at all you want to learn surgery with me, and there are various other educators which are present on the platform, and you will enjoy our interactive learning and that particular platform, just try to explore it out. So if at all you wish to be a part of this particular platform, you can use the promo code surgery101, and if at all you use this particular promo code, you will get 10% off on whatever the subscription which you decide to take. At the same time, you can also take a combined subscription of Unacademy as well as Preptider together, which is called as an iconic subscription. You can definitely consider taking it, and again, the same promo code will help you in getting 10% off on whatever subscription which you wish to choose. Thank you so much, guys. It was indeed a pleasure interacting with you. Have a great time. Happy studying. See you in the next session. Bye-bye.